What's up, y'all? Welcome to the Sports Medicine Broadcast Shoulder Anatomy. We're talking about tips, tricks, and reviews, and then we're going to talk about just some weird things that we've seen just as we work to improve our understanding and evaluation of the shoulder anatomy. So I've got Marcus Knox, physical therapist for Memorial Hermann, also a Rice University graduate. I'm sorry, Bubba. Yeah, I know. Okay, so we got Marcus Knox. Let me switch over to his camera there if you're watching live. Marcus Knox. You got to see he's got his Methodist shirt on.
Yep. He looks good in front of that backdrop, though.
And then we got Bubba. We got Bubba Wilson from Memorial Hermann over there, and the athletic trainer. Also, he's been on here quite a few times. So I am, of course, Jeremy Jackson, host of the Sports Medicine Broadcast, and then viewing or via Google Hangouts video call, we got Matthew Frericks. It's like Fredericks without the D, right?
Correct.
So Matthew Frericks. Did I say that right, Matthew?
Yeah, you did.
There we go. Good. This conversation is sportsmedicinebroadcast.com. Again, sportsmedicinebroadcast.com// shoulder anatomy. You can tell that I've been absent for like 3 days, huh? I'm just not with it. All right. So as we're talking about shoulder anatomy, we're going to kind of go over a review, talk about what's here. We're going to talk about tips, tricks for kind of finding those things, identifying those things, and then just again, weird things that we have seen. And then over the next two podcasts, we're going to talk about evaluation and rehabilitation. So without much further ado, Marcus, you got a lot of notes in here. And Bubba, of course, you know how this works. And then Matthew, anytime you get questions, comments, concerns, something to add, just jump right in there. So Marcus, why don't you start us off?
I would argue it's a joint. I would say it is. I mean, you could argue patellofemoral is not technically a joint either, but it's considered a joint. So
we're just going to say four joints. Kind of go like that. Right? Muscles, kind of divide it up. Now, most people just say, hey, you got your rotator cuff muscles and your deltoid muscles, and that's technically, all the shoulders and the muscles. But there's actually a lot of different muscles. I'm just going to kind of touch on 13 of them. Some of them, like people say, there's more, maybe kind of 20, 22 if you want to throw in, triceps and things like that. But these main parts of the muscles of the shoulder, we can kind of go into that. The first one I'd say is more the thoraco-scapular groups of muscles. That's going to cover your traps, your levator scap, your rhomboids, your serratus anterior, and your pec minor. So with this group here, we can kind of go through, kind of what they do. Now, we have the traps, and we have the upper trap, middle trap, lower trap. The upper trap is going to be in charge of actually elevating the shoulder blade, as well as upperly rotating the shoulder blade as well. Your mid trap is going to help with actually retraction of the scapula, while your lower trap is going to be more of a depressor and upward rotator of the scapula. And they're all supposed to work in junction with one another. It tends to be that the upper trap is more active. And if you look at it as far as a muscle imbalance and they're all working together, that upper trap seems to be more active with people with shoulder issues, and the lower trap is not active or very weak. So we tend to try to equal out that balance, that muscle imbalance when we're treating the shoulder. We can talk about the levator scapula. It's going to help, adduct and downwardly rotate the scapula. The rhomboids, they're going to adduct as well. They're going to help with downward rotation. Your serratus is going to actually abduct the shoulder blade, and it's going to help with upward rotation. And it's also key because it's going to stabilize the scapula as well, against the actual thorax, or the thoracic part of the spine there. Or the ribs really. And then we have your pec minor. Pec minor, you can kind of see if it's actually supposed to tilt the scapula anteriorly, and you're going to see a lot of you see the athletes with the rounded shoulders, and then, the chest muscles are a lot more tighter, and their back muscles are a little bit more spread out. So if you have anybody that's kind of winging as well, that's mainly because that pec minor is actually tilting that scapula a little bit more anterior than it really should be. We'll touch on it a little bit later, the really good importance, the importance of the motion of the shoulder blade and its relationship with the shoulder, and how it can actually cause more issues with it if it's not on the same page with the shoulder. Um, Second group of muscles, we have the thoracohumeral muscle group. That's considered your lats. The lats are going to actually help adduct. They're going to help extend the shoulder, and they're going to help with internal rotation. Okay, your pectoris, your pec major. I'm sorry, pec major is going to help with adduction of the shoulder. It's going to help with flexion, and also internal rotation. Excuse me. Um, Finally, you have your scapulohumeral groups of muscle. That's going to be your deltoids, right? You got your anterior, your middle, and your posterior deltoids. Supraspinatus, infraspinatus, get kind of rotator cuff muscle, subscap, teres minor, and major, right? As far as teres minor and major, they're going to help with, teres minor is going to help with external rotation. It's also going to kind of help with the actual glenohumeral stability of the shoulders. Your teres major is going to help with internal rotation and actually helps with extension and adduction of the actual shoulder. Subscapularis is going to also help kind of depress the shoulder blade. It's going to help with internal rotation, and it's going to help extend the humerus as well. Your infraspinatus is going to help with depression. Depression and externally rotation, and also extension of the humeral head. And then, of course, your supraspinatus is going to also help with abduction, depression, and then externally rotate the humerus as well. Finally, we have your deltoids. The anterior portion of the deltoids are going to help with abduction, flexion, and internal rotation, while the middle part is going to help with abduction of the humerus. And then posterior aspect will be doing a abduction, extension, and external rotation. So these groups of muscles, they all need to be working together, kind of like, transmission of a car, shifting from gear 1 to gear 2 to gear 3. And there needs to be a nice smooth transition. So when one group of muscles, like for example, the upper trap, is doing a little bit too much activation, it can throw off the actual mechanics of the shoulder. In between, there's a small space, the subacromial space. It's a very small space, so there's a lot of things going on there. I mean, you got the bursa, you got tendons from the supraspinatus, and a lot of other things going along in that shoulder. So if you can imagine, if the shoulder blade is not moving correctly, it's going to put a lot more pressure on those tendons and different things like that. That's how you get your chronic rotator cuff tears that, nobody's really hurting themselves, as far as the mechanism of injury, but over time they'll have that a rotator cuff tear because they're micro tearing that tendon over and over again due to impingement. Okay. As far as the muscles here, that's pretty much a wrap up.
All right, Bubba, I saw you jotting down some notes. You have some questions or comments there, Bubba?
I will, not now.
Okay.
I think one of the things that's probably left out, from a muscle standpoint, and you've got it sitting there, which is biceps itself, which is a humeral head depressor.
Mm-hmm.
And so, I mean, that the muscle belly itself, fibers, is not in the shoulder joint as we know it, but it's a pretty important piece of anatomy in there, and I think you're fixing to touch on it. But I do want to. I'm going to go ahead and jump to it. I lied, Jeremy. One of the things you were talking about is that rounded shoulder thing, and so your upper traps are overactive. Your anterior muscles, your chest muscles, are overdeveloped, overactive, and you look like the big muscle bound guy that can't function because you are a big muscle bound guy that can't function.
True.
And so anybody that's an overhead athlete is already at a mechanical disadvantage, plus they're at a functional disadvantage. And so your guy that, they like their mirror lifts, bench press, bicep curls, those things. And we've talked about it before, and we're going to talk about it within this, I'm sure. And I know I'm jumping the gun a little bit, but I think it's important when you talk about all these things having to work in conjunction, and there's, scapulothoracic rhythm and all these other aspects that go with this, is in the weight room, in the athletic training room, in the physical therapy clinic, these things that have to be done to balance is a 2-to-1, 2 pulls to 1 push minimum. And I think a lot of people, I can't say forget it, they overlook it, because if I can't bench press and I can't be an athlete in theory, which we know is wrong at this table at least. And so I think that as we go through this, something to just keep in mind. We don't do enough work on the posterior side at the upper extremity level or the lower extremity level. And so hopefully 2 weeks from now, as we talk about some of that, a lot of our focus will be in that area.
I totally agree with you on that, because it really boils down to that ratio of the scapula and the humeral joint, like you said. So it's really actually a 2-to-1 ratio. So every 2 degrees that the the humerus is moving, for example, flexion, you're going to get 1 degrees of actual abduction from the scapula. So if you already have a disadvantage because it's anatomy wise in the wrong place due to upper trap or cross syndrome, you're already, like you said, put yourself in a functional disadvantage. And then that we need that scapular mobility to actually properly upperly rotate, and those muscles are throwing everything off. You're putting a lot more tension on that humeral head and those tendons. So
if I'm an overhead athlete with rounded shoulders, I can't function as I need to. As I steal from Dr. Meister, his analogy is probably the best. The better I can cock the gun, the better I can fire the bullet. And if I can't externally rotate to the extreme, a safe extreme, then I'm at a disadvantage of firing the bullet, doing whatever I'm doing upper extreme, be that throwing a ball, serving, hitting a volleyball, throwing a ball, hitting a serve with a racket, swimming, right? Whatever it is, I can't do it because I can't create enough forward force because I don't have enough time lever arm wise to bring it forward. So
and that it makes the importance of why we do functional screens, because we want to see if we can catch those type of things and kind of address them before they end up being a problem.
That's a whole other topic.
Yeah,
all right, Matthew. So what you got so far, Matthew?
Well, kind of what Bubba was already alluding to. Marcus already went over the anatomy, and then kind of everything I was already thinking. Bubba kind of already touched on it. Kind of like the overlooked parts is kind of what I see a lot, and that goes with like just a lot of professions. Is a lot of people just look at like what you alluded to is the posterior part. Like what I see a lot of people is like, oh, they just focus on the pecs and the biceps, and they totally forget about everything else. And that's when, obviously, we know sitting here is like, that's when a lot of stuff can start to come on when they're only focused on that one part. So basically everything I was already thinking, Bubba already kind of touched on.
All right, Marcus.
Okay, so we'll kind of go into the tendons because we already kind of touched on it. Bicep tendon, you have it's 2 heads. You have a long head and you have a short head. The actual long head is going to kind of connect to the superior glenoid labrum. Then your short head is going to connect to the coracoid process. Supraspinatus tendon, that's going to be inserted in the superior facet of the actual greater tubercle of the humerus. So that's one of these tendons that's going to go through that subacromial space. And as we already kind of touched on, if that scapula is in the wrong angle or it's not moving like it needs to, that's going to cause, it's really not a lot of space going through that subacromial, and there's a lot of stuff. So there's that stuff that's already in there. You got the bursa and things like that. So you're already putting yourself in a disadvantage functionally. And then as far as anatomy wise and injury prevention type things, you're going to increase your chances of injury, especially with impingement, just kind of chronic impingement. You also have the subscapularis that's going to insert more in the tubercle of the humerus and then kind of more the front part of the capsule of the shoulder joint. your inverse spinatus is actually going to travel more at a diagonal and kind of inserts more on the greater tubercle of the teres minor. That's going to kind of connect to the greater tubercle of the humerus, and all these muscles they're crisscrossing each other. And if you actually look at where they're inserting, you can kind of see what they're already going to do, what their job is going to do. So if we have one muscle, like for example the lats, they're coming from the lower part of the back, and they're going to cross actually in front of the actual humerus and connect to the front. So if you look at it as a lever, it's going to actually pull that arm into internal rotation, right? So just kind of paying attention on where all of these, insertions and origins of these muscles and tendons, you can kind of already see. If you have to kind of take, kind of dissect the shoulder and just look at the actual single muscle and tendon, you can see what that actual function is of that muscle and tendon. I think the next one we're talking about was ligaments.
All right. Bubba, you got anything else over there?
I'll wait till after ligaments because I do, but
Okay.
it all ties in.
Today, ligament-wise, we have coracohumeral ligaments. There's actually three of them. There's a superior, there's a middle, and there's an inferior. It's actually shaped, and when all three of them are, of course, working together, they're actually going to be shaped anatomy-wise in kind of the letter Z. They're most likely they are taught at external rotation, and they have some laxity in there when there's internal rotation. But as far as testing, and we'll kind of touch on it next week as far as with the evaluation of the shoulder, we can talk about how they're actually tested. Superior coracohumeral ligament is going to be more in charge of external rotation and keeping the stability of the shoulder when it's more kind of at 0 degrees. And then you kind of go to the middle, coracohumeral ligament, that's going to be more important, more kind of at 45 degrees. So the way these fibers are laid and where they're actually
We repair the labrum we still lose that suction, that negative pressure. Whereas in the hip, being as deep as it is, you can repair it. You can have a labral tear and be relatively stable in the grand scheme of things. Repair it and become very stable again because you don't, for whatever reason, we're not losing the pressures at the same amount. And so, well, and we'll touch on it again, but a lot of the stuff out of Dr. Andrews and those guys is talking about, if you're not a major league pitcher and you get a scope put in your shoulder, they don't even have to repair anything. You got about a 0% chance of becoming a major league pitcher just because we've disrupted that vacuum in there. And so we can never get it back. You can't put a vacuum hose in there and suck it out and seal it. It just doesn't work. And so, I've got a labral tear. I've got to get it fixed. Okay, you're better off getting it fixed potentially, but you still may never be at the level you were at previously.
So, I just recently had a patient that they chose not to have their surgery, and of course, it's the labrum is not very vascular, so it's going to take time for it to heal. So the best thing that we were kind of doing is just working on different parts of the shoulder to give it some stability. In his case, it was his posterior muscles were just weak, right? Range of motion was pretty good, but there's still some internal rotation that was lacking. But we focused more on that posterior strength so we can control what's going on. And just like he was saying, once you cut that open, you're going to lose that pressure. Right.
Well, and you just touched on it. We talked about posterior chain, but if we look at what's the misnomer on Tommy John, I'm going to come back stronger.
Oh, it's because of the shoulder.
Well, you quote unquote come back stronger because you've had a year to a year and a half to address all the faults that put you on the operating table.
Exactly. In the first place.
You're never as strong as what you're born with, unless you're born without it, and they have to go put something in. But you're working on all your faults and weaknesses. And so same thing with the shoulder. We can talk about GERD and all these things, but if the stabilizing structures around that aren't doing their job, then it doesn't matter. It doesn't matter what we do. If I'm still rounded shoulders and no posterior, strength, then who cares? You're still not going to be able to, fire the gun. So
I got a quick question. As we're talking about the always says the 2-to-1 ratio, the push-pull type thing. So like if I'm over at the weight room, say I'm bench pressing, say I'm doing like a heavyweight, 5 sets of 3 at 315, but then I go over and do like the TRX rows, each time I do a bench press, I could do kind of like a circuit training. So then I do like 10. Does that count? Since I'm doing 3 reps on bench press, but I'm doing 10 on the TRX rows, but it has to be, you're thinking 2 completely different exercises. Or does it need to be equal?
You could do TRX rows, but then you would need to throw in something like reverse flies, for instance, just to throw an exercise out there. 2 exercises, 2 pulls for every 1 push. 2 pull exercises for every 1 push exercise.
What are your thoughts, Marcus?
I totally agree with that, but I think what you're trying to get at is the dosage of it. Is that what you're trying to get at?
Right, because if I'm doing only 3 bench press, but I'm doing 9, 10, 12 of the other one, does it not count as twice as much?
I think I'm going to say no, because I think you've got to get the 2 different pulls in there, not double your pull reps to your push. I think you've got to change it. My personal opinion, you got to change it up and get 2 different exercises.
Okay, fair enough.
I still think the reps matter, but I think it's in a perfect world, 2 different exercises, if that makes sense.
Matthew, thoughts?
Yeah, I kind of agree with that. Going on about the 2 exercises, I kind of see that along with, because I'm more often now when I'm looking at the exercise, especially with the posterior side, I'm more looking at reps, more exercises and kind of higher rep kind of thing.
But I'm just going to play devil's advocate. What if we do? What if you're looking at the anterior portion and you're looking at more endurance on that part, and then you're going to focus more on the strength part with the posterior stuff, so lower reps on the back. Because that's technically what we want to do is strengthen the back.
Right.
You want to go ahead and get that pump or whatever, for the front, but functionally we want to strengthen the back. So I would say what you're saying, but kind of flip it. Like you would want to maybe strengthen the back right? Or do more of a 8 reps, 3-4 sets of 8 versus doing shorter on the front. What are y'all thoughts on that?
I'm gonna not argue. I'm gonna say there's no bad answer as long as you're addressing
as
it.
long as
Because I think we can argue all day. Well, I think again, my personal philosophy is 2 exercises.
Yeah.
Okay. Now it'd be fun to play around with and say 2 exercises versus double the reps. What's the difference?
What's the difference? Yeah.
That'd be fun to look at. But I think something's better than nothing.
Yeah.
Unless it's done wrong.
As long as you're just addressing that
fact.
Yeah.
And so again, we all have our favorites, but are we doing something, what are we doing for glute ham for, lower extremity stuff? We better be doing something. Maybe not, I'm not doing the same exercises that Matthew would do that you would do, but I'm doing exercise, right? And so at least we're addressing it, which is the start. And that's really you're further ahead than a lot of people.
The education part is the first thing we need to kind of address, but
yeah.
I also think sometimes it depends on who you're working with, your type of, I think, patient. In my experience, I've worked with a lot of like overhead softball and baseball, and the posterior side, I'm trying to get them strong, but I'm looking at it more as like functionally strong. Like kind of finding that 10 rep max or 10 to 15 rep max and kind of getting them to that point is normally what I think sometimes when we're looking at strength, I think it all depends on kind of what your patient is. If you're working with an athlete or just your weekend warrior type person.
Yeah, and I totally agree with that. You have to see what type of athlete you're dealing with. Of course, swimmers, you're going to need more endurance. Your pitchers, you're just going to be that quick power that you'll need, over and over and over again. So as long as you're addressing the type of athlete, what they're doing, right? I feel like you can get your dosage, and you can play in your dosage a little bit more.
And I think we also, and again, we're jumping the gun, but we're not. In a couple of weeks, we'll talk about it. But and it's the wrong word, but you can't forget the core, and you really can't forget the lower extremity, because if they're all not strong and they're all not functioning together, doesn't matter how good your posterior chain is in your upper extremity, you're still going to suck.
Yeah, you definitely need that mobility as well.
Yeah.
If I'm an overhead athlete in a ground-based sport and I can't transfer the ground forces up, then it doesn't matter
properly. Yeah.
Right. Swimming's a little different. So your core really is almost your ground for your swimming. And so my core, which is a bad term, but core stability, we can argue that again. But if I don't have that, then it doesn't matter. And so all those things have to work together. Why do we put a pitcher on the DL for a bad toe?
Because you need that.
You've got to be able to transfer. And if we can't transfer, we change our mechanics. Something's going to give. Yeah. And so, we know it's a total body process to have a good upper extremity function in an overhead athlete.
Yeah, I would totally agree with you. It's when we are doing, the way we do our evaluations at our clinic, we look at the actual cause of the cause. You come in with elbow pain. We're not just going to treat your elbow. We're going to look at the shoulder. We're going to work up the train. We're going to look at shoulder. We're going to look at the scapula. We're going to look at thoracic rotation. And if they're lacking, you have a picture that can't follow all the way through because he's a right-handed, and his left rotation, he does his left rotation, thoracic-wise sucks. And like you said, that transfer of power, of force, is going to go through that thoracic. There'll be issues. It's going to put more stress on the shoulder blade. It's going to put more stress on the shoulder, and it's going to end up not going through that hand, but putting more pressure on that elbow.
Right. Then how much have you abused it? By how many innings have you pitched? And all the other things that go with it. So, I think one of the things that when we talk about anatomy that I've learned at being an old guy, and I really got lucky working for Dr. Lowe when this really all kind of clicked, is, to me, there's 3 levels of anatomy, if you will. There's textbook anatomy, there's clinical anatomy, and there's surgical anatomy. And in my opinion, if you can get to where you can view all 3, you're a way better clinician in the long run. And people always argue, why does the surgery matter? The surgery matters a lot because, number one, as an athletic trainer, we got to be able to explain to our athlete what was done. But to be able to do that, we got to understand what's in there and what was wrong. And if I can look at something surgically and I can go back from there and say, okay, clinically in an eval, and go back from there and say textbook wise, I can eliminate a lot of crap I don't need to deal with in an evaluation, right? I don't need to do 400 tests because a good history and understanding my anatomy, I can rule out a lot of things. And now during that eval, if it doesn't add up, now I start adding those back in, but I don't need to go look at X, Y, and Z when I could have gotten by with A through D, you know? And so, and again, that's my personal opinion, but that being able to take those three and put them all together, it really changed things for me as far as how I do an evaluation and what they tell me when I'm thinking, because you can say, okay, well, in theory, the whole posterior side shouldn't be a problem. We're looking, maybe slap a little bit posterior, but, bank hard or one of these things. And so we're not too worried about this unless things don't add up.
I totally agree with you on that, because especially when it comes to having a pain generator, a lot of people come in like, oh, I have, posterior shoulder pain. And it could be something going on posteriorly with, muscles or the capsule and things like that. I mean, capsule posterior mobility. But sometimes that's the way that they actually go into the actual shoulder.
Right.
So surgically, it's nothing that's an issue. It's just, hey, that's just kind of where they went in.
That's got to heal.
That's got to heal.
Yeah.
They sewed that part back up, and that's why you had that kind of pain. And you kind of dive too deep and we're like, hey, it's this and that and this, and it's something super simple like that. If you knew that surgical procedure and what he actually did, that kind of eliminates, what you really need.
Right. You don't need to go watch 100 rotator cuff repairs, to understand that. But I think the more you can go in and view, the way easier it is to understand what all was done, knowing, oh, you're right, they take this angle to fix this.
Exactly.
Exactly. And being able to then translate that back to the patient to say, well, look, you need to understand where are all your poke holes, that you're going to have pain right there,
Scar
including
tissue can build up in those same spots.
all those things, all that went into that. So, yeah.
All right, so before we get to the tips and tricks, Marcus, I see you're drinking the hoist hoist hydration I have out for you. What do you think about the, was that watermelon?
It's a watermelon flavor. That's pretty good.
Pretty good.
I've never had it. I didn't know that it was flavored. Until I drank it. I was kind of like, I was like, this is watermelon. I know what it tastes like. I've experienced that before.
My favorite is the orange, and the hoist is kind of partnered with the sports medicine broadcast. And so, they send me some so that I can make sure I have it for you guys that are here, adding value to us as athletic trainers. And then also there's some benefits for people who order using the code TheSMB. Some of those orders will be matched up to like 4 cases. So if you order from there, but you can also check them out. So again, they'll be having some stuff for our NATM giveaway, but we're going to get to tips and tricks. So Marcus has done a fantastic job going over the anatomy, and obviously Bubba always knows something about something. So
just ask me, I'll tell you.
All right, Matthew, you got any tips and tricks for identifying muscles, bones, ligaments, tendons, and the shoulder?
Oh boy, tips and tricks. I think sometimes when I get asked that, how I find stuff is I kind of just go back and what I learned, kind of go back to what I learned in school, because that's kind of where I learned most of my tips and tricks. And one thing I use, for example, is like the rotator cuff. Is I basically just think of the SSIT, just sit, and that kind of just those acronyms kind of things. If you can somehow, whatever acronym works for you, like that one always works for me. Subcap, supra, infra, and then teres minor. That's kind of one tip and trick I use for the rotator cuff. And I forgot kind of how you just lay your fingers out, just kind of right on that humeral head. It's kind of how sometimes I always find those kind of things for the rotator cuff.
That's definitely one thing that I use as well. And another way that you can do it to kind of expose more of that rotator cuff, those rotator cuff tendons, is actually put their arm in a little bit more extension. So I have to, you passively bring them back, and then you can actually palpate and say, hey, how's this feeling? Is this tender? Things like that. So kind of extending that arm and exposing more of those rotator cuff tendons is a nice little trick that we do during evaluation. Finding bicep tendon, you put your finger, your thumb, kind of where you think that kind of greater trochanter is, put them in 90-90, and then you just kind of externally rotate and internally rotate back and forth, and you'll feel greater trochanter, lesser trochanter, just kind of, and that'll be right in between that, once you kind of feel those two little humps, right in between that'll be your bicep tendon. And that way you can kind of use your palpation skills and kind of track down, hey, this is kind of bothersome with them, on top of, your MMTs and things like that.
All right, so going from the bicep tendon, because I think that one is typically pretty easy to identify. So where would you go next in identifying? Because I see the picture you have here in the show notes again, sportsmedicinebroadcast.com/shoulder anatomy. Marcus did a fantastic job of putting in show notes and just things to help us there remember and review. But you got a picture of a hand on top of the humerus, and I think the thumb is where the subscapularis would be, but obviously you can't put your hand right on top of somebody's
Subscap, yeah.
Yeah, their humerus just like that. So talk to me a little bit about, you found the bicipital groove, you found where the bicep tendon is. So where are you going to poke next, and what are you finding?
So if you have, let's say, for example, subscap, we can start there. Subscap is going to be on the anterior portion of that shoulder blade. So I'll bring them out into kind of 90-90 abducted. And then you're going to take, let's say you're looking at the patient's left shoulder. You're going to take your left hand, put it against that thoracic, and you can just kind of slowly inch your way, just kind of follow the curve of that, of the ribs. And then you can actually get in between that shoulder blade, and that's, you can actually see and feel that subscap. It's going to be super uncomfortable. Then you can compare it to the other side. Hey, does that feel? And that's how you can kind of feel. That's what I kind of dive into. And if it's a soft tissue thing we need to work on, then we do it. Subscap, soft tissue massage, and we're working on that. Of course, we'll kind of go to the posterior side and trying to feel some, if there's any, teres minor or teres major, any kind of tendons on the back that we can kind of palpate and see if that kind of flares them up. I think that's about it as far as kind of the palpation wise. Your coracoid, that's always going to be kind of tender there.
I think for me, where do you go next is based off what's going on.
Yeah.
Again, knowing your anatomy in the three ways, if you tell me A, why am I going to Z?
Mm-hmm.
I need to start, I'll argue I need to start most directly and then branch out from there as things don't make sense. I don't think you work global to focal.
Mm-hmm.
I think even on a knee, where's it sore? On the inside. Oh, joint line or MCL is where we're going, right? We're not going, oh, let's look at the hamstrings first. No, we're going to the spot and working out from there if things don't make sense. I think that's my personal opinion. That's how I do it. So we've got pain here. Okay, let me start there. You're not really sore there. So let me move over to the other structures that are nearby, and let's go from there. And that gives me my blueprint, kind of my map of where we're going.
And I'm kind of glad you said that, because like you said, you're starting in that one position and you're going out. So you have pain with adduction coming across, like shoulder adduction. They're kind of pinching right there in the anterior part. So I'm going to look at that AC joint. I'm going to look at the distal and proximal part of the actual sternum of the clavicular. So we're going to go all the way down to the sternum. Okay, there's movement going on there.
Mm-hmm.
Right? It's going to glide. It's not a lot, but it's going to glide in the anterior, posterior. It actually kind of rotates a little bit. So I'm feeling to see if there's any hypomobility, or it could be a hypermobility that's causing the pain in the actual shoulder. So we're going to go spread out. We're going to check AC joint, see how that's moving. We're going to check the SC joint, see how that's moving. It's like you said, it's just not that one area, right? And then of course you're also going to check the mobility of the the scapula, making sure that it's rotating. It's so many patients that come in with shoulder pain and, just picking their arm up. And if you actually have them pick their arm up, they're like, oh, it hurts. And then you say, okay, I'm going to assist your shoulder blade as you go up. Let's try it again. And then it immediately, okay, it feels a whole lot better, or it's really no pain at all. And that tells you right there, okay, that's one issue we need to address.
Mm-hmm.
Do some scapular moves to kind of get that mobility back. So it's not just that one spot. Just because they have it in the anterior part, like you said, what is the cause of the cause? Like, what is causing the pain, right?
Well, and I know we'll get into it in a while, but let's just say my shoulder or elbow's hurting, and the PCP that referred them to therapy never cleared their C-spine.
Oh yeah,
and they got a disc, and it's not even lateral or medial epicondylitis that they wrote it for, or whatever, or rotator cuff tear. They've got a disc problem, and you've always got, especially in upper extremity, no matter if it's wrist or whatever, you got to clear the C-spine.
You got to clear the C-spine. There's so many different cases where they have radicular pain, you know, the numbness, the tingling in their hands, you have to check that C-spine out. It might not even be the actual C-spine. It could be the first rib just kind of bumping into that brachial plexus a little bit, just because it's elevated. So I mean, there's different. You have to look at the person globally, functionally, and not just zero down on just one spot, right?
And to me, again, it goes back to knowing the anatomy. You don't got to know it intimately. I mean, we're not doing surgery, you know, and we're not reading MRIs and dictating reports, but you got to know it because, again, hey, I'm getting numbness and tingling. Well, all right, we got to clear C-spine. That's clear. Well, we got to look at thoracic outlet. All right, we got to clear that.
Yep.
You know, we got to work from one spot out. So the first spot I'm going to go with numbness and tingling, I'm going to the neck.
Yep.
And that's not the neck. All right, got to look at thoracic outlet. No, it's not that. All right, now this gets fun. You know, now we've got to really start drilling into what it could be if we can figure it out.
So then again, what you just said, Bubba, is exactly why I wanted to kind of go over the shoulder, because so many people say start with the anatomy. That's what you know. Start with the anatomy. Well, what if I don't really know the anatomy? That's why I wanted to again go over the review. You know, obviously I can go back to the textbook, but it only translates so much. And so, what can I put my hands on? And I know over and over again, you said you got the 3 different types of anatomy: the textbooks, the clinical, and then the surgical anatomy. And going to surgery is difficult, more difficult now than it used to be. And it's just one of the things you have to make an intentional effort to do. And, you know, you part of building that relationship with your team doctor or whatever it is, your local orthopedic. But let's talk a little bit more about just ways to help identify. And again, this ties so much in with evaluation, and we're going to talk more about that later. But I want to, again, as much as we can, focus just on ways to identify the anatomy. So any other things you got to help focus on identifying the anatomy?
Let's see. So we can start with kind of positional faults. You can see where the scapula is placed. Normally, you know, the inferior border is going to be kind of around T7 area. Superior border should be kind of around T1, T2. Then that kind of the spine of the scapula should be about T3-ish. Okay. So first thing, just observation wise, see how they're sitting, see where they place. Are they, and then also you should be about 3 or 4 fingers from the spinous process to the actual scapula. So if you're seeing that it's a huge gap in between T-spine and the medial border of that scapula, that's telling you right there that there's going to be some type of functional limitation. So visually, you kind of want to just look at everything as a whole, as far as just the original placement on where it's actually starting.
I think a good thing to do if you can find the right guinea pig, and one of your boys would be more than good, get their shirt off of them or get them in shorts, draw, find it, mark it.
Yep.
Draw it. And then all of a sudden you'll be like, oh, that makes sense now when you can see it that way. You know, find mark the AC joint, you know, palpate the coracoid, find the biceps tendon, mark it somehow, whether that's a line on each side of it. So you kind of know this is where it's running, whatever it is, draw it with a marker and, you know, graffiti them up and, you know, kind of put dots where the border of the scapula is, and kind of, you know, looking at those and being able to visualize this is how the scapula is sitting, and if you could do both sides, because all of a sudden you'd be like, ooh, they're winging, and you couldn't see it without the marks. But then you can take them off and look at your kid and go, now I can see it perfectly. You know, and so I think, you know, if they'll let you mark on them, you know, I mean, I do it all the time myself. If you've got a bad knee injury, I'm marking where the distal pulse is so I can go find it again. But why aren't we, you know, let's learn anatomy the same way. Mark it with something that's going to come off, not a Sharpie, you know, like I would use on that, but that you can visualize it. I mean, it works great.
And not just using just one person. Everybody's different. So different type of body types. Of course, everybody wants to go to the more, you know, skinnier person so you can kind of see what the anatomy is, but go and get you somebody that's a little bit thicker, you know, got some, you know, body tissue, so you can really test your skills, because not everybody is going to come in easy to kind of.
Looking all sore like you, Marcus.
Yeah. No, they don't all come in. No, but yeah, you just kind of, as far as practice wise, that's one thing we did in school. That's one thing we did in our fellowship. We made sure that you touched every type of body type, right?
That's good.
One more.
Go ahead,
Oh,
Matt.
go ahead. I think one thing, just looking at like if you're like a student or like somebody that's just coming out in their practice, I know that one thing that worked for me and that worked. It's kind of what I learned in undergrad. Is Ray had this book. I think it's called like Trail Guide of the Body.
Trail Guide of the Human Body. Yep, phenomenal.
That it is.
Yeah.
I really recommend that one to like AT students or PT students that I come into contact with, because that book goes over every muscle and it gives you every position on how to, palpate or find that muscle. It gives them prone, it gives you sideline. And I think all experience levels, I think you can use that, because I think that's where the guinea pigs and just more practice comes in. Like if you really don't understand it, then bring that book out and it shows you, and it gives like a picture of that, like of just a normal textbook body. And I think it gives you a little bit, like you can try to translate to that actual person.
Yeah, no, the Trail Guide to the Human Body is probably the millennials version of our anatomy coloring book.
Oh man, I was just about to say that.
Probably,
that coloring book
probably
saves wonders. You make a copy of it and then you just color it once, twice, and just kind of follow that.
The Trail Guide to the Human Body is phenomenal.
Yeah.
I was just about to say that coloring book.
Yeah.
All right, so just a quick Amazon search: Trail Guide to the Body, how to locate muscles, bones, and more. It's $60, spiral bound. I'll have a link to that there in the show notes, but Trail Guide to the Human Body, so I'm gonna have to check that out. But I really like the idea of drawing on the boys. I've done that in sports medicine class, but it's pretty limited. You can't just have everybody kind of rip their shirt off, but there are guys that would be willing to, take their shirt off, that kind of thing. And so it's a really good idea. Even for me teaching the class, I get to practice on them and remember by just drawing on them. So we've gone over all the anatomy. We've talked about some tips and tricks. And now let's talk about just some of the weird stuff that you have seen or you've had to identify or rule out. It's like, okay, well, I've heard of rib resection or whatever it is. And so when you're palpating, well, that feels really weird, that kind of thing. So just some of the weird things you have seen in shoulder anatomy.
It's weird and challenging. One case, it's adhesive capsulitis. I can't, and frozen shoulder. It is one of the trickiest things. It's tricky to treat. It's easy to kind of
diagnose it, yeah.
But the prognosis, it's too wide. It's too long. It can vary from a couple months to a year. In the treatment wise, it's, do you be passive with it? Do you be aggressive with it? There's a lot of research on it. They're still trying to figure out what is the true reason on what happens. I mean, other than post-op,
is it
not
RSD?
moving. But the actual just people that just wake up one morning like, hey, I can't move my shoulder.
Well, the problem is you could put them under an anesthesia, manipulate them, and then they're going to wake up and 3 days later be frozen again because for whatever reason. Even putting them on a CPM, they gradually, I'm losing my motion.
Yeah.
Why?
Don't know. And they've did some research on it, and they're saying, it's more hormonal, especially
more common in females,
menopause, things like that. But I mean, even males, they said it's either, stress levels, it could be diet. I mean, it's the list goes on what's actually the cause of it. But passive, I mean, the treatment wise on it's like I said, I've had people that are like, hey, just push my hand back, push my arm back, be aggressive with it. And, you're aggressive with it. It works sometimes. It doesn't work. Okay, be passive with it. It works sometimes. It doesn't. And what really makes it more difficult is actually they can't lift their arm up. So then it jumps into, I'm using my upper trap, firing my over trap over and over and over, just so I can pick my arm up and grab something out. So then you're fighting that case as well as upper trap, lower trap. Right, because they're doing a lot of compensation. So it's a tricky one for me as far as when they come into the clinic. And then emotionally, psychologically, you're dealing with, every time I come to PT, it's painful, or hey man, I just want this to be done with. So it takes a lot of patience, and it's probably one of the because I can't grab it,
right.
The concept of, because what's actually happening is that capsule is just shrinking, and it shrinks. And it does not want to move. And as far as evaluating it and, diagnosis, and your lack of external rotation is the first thing that goes. So they're gonna have the greatest limitations with external rotation. When you start to see that, and then it goes into abduction, they can't abduct as well, and then they can't flex. The flexion will probably be the most range of motion that they'll have, but you take that arm in external rotation and it stops. Try to take it in abduction and it stops, and you take it in flexion and it stops. That's going to be most likely your frozen shoulder. So it's one of the trickiest ones, man. I super weird for me sometimes.
Pat, Bubba?
Go ahead.
Yeah. I think a weird one. I mean, we've all heard of the thoracic outlet syndrome, but I think it's still weird to me. In my first year as a grad student, I came across softball pitchers that had it. And that was kind of when I really learned more about it, is that it can be neurological, or it can be like it can, I think, because what happened is like this girl was constantly having radiating numbness and tingles down to her fingers. And I'm like, well, this is what I think it is. Kind of took her out of softball. Well, one night she woke up in the middle of the night and her arm was blue. Well, her arteries kind of got pinched, so she had to kind of go get almost like emergency type surgery where they had to, I believe, take out her subclavian, which is a muscle that a lot of people forget. It was kind of tight. Then they had to dissect I believe the distal fourth of her first rib, which after that surgery is kind of weird to feel. That's why I would have my students palpate that one. But that one is always a weird one to me, because that's always the one that I learned about in undergrad. But I was like, I'm probably never going to see it. Well,
yeah.
2 years out, my first injury that I basically saw as a grad student was that one, and it was definitely something. And it kind of showed me not everything was black and white. Like you read about the stuff in the textbook, but all of a sudden there's going to be that one case where something like that happens, where a patient comes to you and their arms, doesn't have proper circulation. So that's definitely one that always pops in my mind when somebody asks me, what's the weirdest thing you've seen with the shoulder? I'm like, well, that's normally the one that's the weirdest thing that I've seen.
Yeah, we do deal in a lot more gray than a lot of professions, in that regard.
Yeah.
For me, it's the most challenging one for me is the multi-directional instability person, because no matter what you do, they're not going to do better. And you're still trying to get them to where they can function and play. But I think the weirdest one I've seen is an upper extremity compartment syndrome. So that was pretty interesting. But similar to lower extremity, they open it up and free the pressure and let it go. I think they ended up doing a first rib resection over time, because it was all kind of interrelated, but they weren't a true TOS. They were a compartment at the time. So, that was like, they were what? Huh? But yeah.
Yeah, that first rib will get you sometime.
Yeah, and I don't know. I mean, you guys, the ones I've seen with TOS are typically not skinny. They're kind of like me, bull-necked, a little thicker, because there's less space. Everything's kind of jammed in there. I've never seen a giraffe-necked, skinny person get diagnosed with TOS. So not saying it can't happen, but
yeah, this girl was definitely fit, but being that she was a softball pitcher, it was her pitching side. So I don't know how many, like every softball player I come to contact with, because that side they pitch on, they are, if you just look at them, you can see you are so right dominant, because I can see you are so bigger on that side, because that's the side you're constantly using. Right. I think that definitely played a part into it, because her right side was so much more, I want to say more muscular than compared to her contralateral side.
Right.
She was definitely a fit girl. It was just that side.
All right. Any other tips, tricks, thoughts on anatomy of the shoulder as we continue next week into evaluation, and then the week after Thanksgiving, at least when this is being recorded, on rehabilitation? Marcus, anything else?
I've noticed, and what I do a lot in the clinic as far as helping with stability of the scapula is more closed chained scapular stability exercises. Whether that be, and then you're trying to do it, and it's tricky because you're trying to be a little bit more creative, because the serratus is really going to be more active when the arm is kind of a little bit over about 110. So exercises that activate those muscles when you need them the most is tricky. So I'll have them do bear cross, but they're reverse bear cross. So you're actually pushing away. We do a lot of, I call them, drunken bar, where you have a bar in your hand, you have a kettlebell on one side, and then a 10-pound kettlebell and a 5-pound in the back. So you're holding that over your arm, creating stability within that shoulder blade. So it's tricky on trying to keep it close chain as much as possible, but that's one thing we pretty much do a lot in the clinic. I mean, you got your step ups and things like that, close chain wise, but that's what we kind of do a little bit most in our clinic when it comes to our baseball players, because they need that stability.
Close chain in the upper extremity is hard because we don't walk on our hands,
Exactly,
and so you gotta figure out ways to do that. And we'll talk about it more, but I think one of the things I saw is like stacking up plates at different levels, and you have to do push-ups. Like one hand's on the floor, one hand's on the plate, push up. Next hand's on the plate, the other's on a different level of plate, so you're kind of unstable at the same time. Just little ways to do that, stair step or step up, or push-ups and stuff. So I think as we talked about it, there's no shame in going back periodically and reviewing your anatomy.
Yeah,
I think we get away from it. I know it, screw it, and all of a sudden, like, wait a minute, where's that insertion again? What's the action? Yeah. So there's nothing wrong with, I don't know, however you want to do it. One joint a month for, look at it for an hour one day. I don't care, whatever you want to do, but go back and refresh your memory,
especially on those biomechanics.
Yeah, and as I've talked about before, like with the kid that had the stroke, cardiac stuff isn't sexy, but we probably ought to remember how the heart functions, and the blood goes from here to here to here to here to here. Same thing. Refresh yourself with that every now and then, just so it's in the back of your head and not, buried under a bunch of other clutter that's in there. It doesn't have to. It's not a long, week-long immersive study. It's 30 minutes, an hour, and be done with it.
And whip out my coloring book.
Trail guide, man, way better.
Coloring book.
Matt, final tips, tricks.
Yeah, I think the final thing is what I normally tell people about the shoulder is make sure you always look at the shoulder as a whole. Sometimes I kind of think of the shoulder as like a cause and effect thing. Like, for example, anterior is, being the cause of the pain, but then what's the effect? It's normally on the posterior side, like what's weak, what's tight. So most of the time I just tell people, look at the shoulder as a big thing. Most of the time it's going to be a thing. That one thing might not be hurting you, but it's causing the second thing, which causing your thing. And I think some people get in a habit of just looking at the one thing, but not looking at potentially the larger problem. Because obviously we're more in about, I want to stop this pain. So what's really kind of being the cause that's making that effect.
All right, so I know watching live, I had at least Craig Lewin, John Harmon, Tilla Henderson, Brandy, Neely, Philip Tucker, and I know that there were more. I just couldn't catch all of them. So thanks for watching live and tuning in. And actually, Matt joined this one because he's interested in starting his own podcast. And once he gets that up and going, I'll have him back on here and we'll kind of discuss what his is and about and that kind of thing. And so, Matt, I appreciate you joining in and helping and desiring to help athletic trainers grow. And so his will be similar, talking to doctors, or kind of taking one topic and getting, a doctor's, a physical therapist, an athletic trainer perspective kind of idea. But that's still in the works. So Matt, I look forward to hearing from you again in the future.
Yes. Thank you very much for having me on today. I had quite the experience. It was a lot of fun. Thank you guys.
Stay warm.
Thank you. Oh yeah.
Thank you. I'll do my best.
Matt, somebody wants to get a hold of you. What's going to be the best way?
You can find me on Twitter. I believe it's ATScoop1. That's kind of my more professional based Twitter handle. I'm also on Instagram. I believe that one's just ATScoop, but find me on Twitter, ATScoop1. I should be right up there.
All right, Bubba. Someone wants to find you?
I don't know what it is.
ATCLAT Bubba.
Yeah.
On Twitter. All right, so find Bubba that way. He doesn't tweet very often, but he catches the messages or whatever. So if you mention him or contact him or direct message him, then he'll get a hold of you that way. So Marcus, somebody can get a hold of you.
Oh, the best way you can buy email, so you can go MF Knox, like Fort Knox, KNOX. So MF Knox at HoustonMethodist.org.
And then, of course, you can go to sportsmedicinebroadcast.com/shoulder anatomy. Again, sportsmedicinebroadcast.com/shoulder anatomy. And again, we talked about the hoist hydration. Marcus had it here. Bubba had some.
It's delicious.
If you come and you're a guest on the show, then I'll have some for you. If you order some, then you get a discount by using the code THESMB. So check that out. And they're going to be, again, with us at NATA as we're in Vegas. And then
I'm looking for Matthew right now.
there you go. And then the resource that they mentioned, either the anatomy coloring books or the trail guide of the human body. Again, I'll have a link there at sportsmedicinebroadcast.com/shoulder anatomy. For Jeremy, Marcus, Bubba, and Matthew, that is a wrap. Thanks, guys.
Thank you.